Rahim. The presentation is on fetal anomalies. We will be discussing some of the common fetal anomalies today. Fetal anomalies, often referred to as birth defects, are structural changes to one or more parts of the fetus body that increases the chance of stillbirth and can cause deficiencies in the child's health, development, and quality of life. Fetal anomalies refer to unusual or unexpected conditions in a fetus development during pregnancy. Causes of anomalies. There are different causes. The main causes are the genetic problems, chromosomal problems, infections, exposure to medications, chemicals, or other agents during pregnancy. Although congenital anomalies may be the result of one or more genetic, infectious, nutritional, or environmental factors, it is often difficult to identify the exact causes. The birth defects can be caused by genetic factors and by a variety of environmental injuries such as infection, radiation, and drug exposure during pregnancy. The majority of birth defects, however, are without detectable cause. About 20% of birth defects are caused by genetic or hereditary factors. The most common severe congenital anomalies are heart defects, neural tube defects, and Down syndrome. Anomaly scan. Ultrasound is the most common tool used to detect birth defects. This detailed ultrasound scan, called anomaly scan, sometimes called the mid-pregnancy or anomaly scan, is usually carried out when you are between 18 to 21st week pregnant. You are means the patient. The 20-week scan is offered to every patient. It is in most of the advanced countries, it is covered by their insurance. This anomaly scan usually takes about 20 to 30 minutes. However, the sonographer may not be able to get good views of the fetus lying in an awkward position or is moving around a lot. Then it can go up to 40 minutes. Fetal head anomalies. This is how we take the fetal head measurements. This is for BPD. And I hope most of you know that this is the falx cerebri, the thermi, the cavum septum pellucidum, the parietal bones. So biparietal means between the two parietal bones. We usually use headlock method for measurement of BPD. And for headlock measurement protocols, we need to take one outer and one inner for the measurement. One is the outer side of the parietal bone, the other parietal bone we will take the inside. It depends which one is more clearer to you. You can take the outer of this one and inner of this one if it is clear. The first anomaly is anencephaly. It is the single most common neural tube defect. It results from failure of neural tube to close at the cranial end of 38th menstrual days. 38 from the last menses. As a result of cerebral hemispheres, the calvarium of the skull do not develop. Skull and cerebral hemispheres are not formed. In anencephaly, the fetus is born without parts of the brain and skull. As the neural tube forms and closes, it helps form the fetus brain and skull, upper part of the neural tube, spinal cord and backbones, lower part of the neural tube. This is the normal hemisphere, the brain hemispheres, and then is the skull bone, whereas here no brain formation. This is how the newborn will look like. This is another one. Anencephaly-Sonographic findings, there will be absent calvarium and most of the brain is absent. We can get a small bud of brain, rudimentary brain tissues visible, which is that bud, bulging fetal orbits, giving the characteristic all eye or frog eye appearance. Hydramnias occurs in 50% after 25th week of pregnancy, which is the polyhydramnias, excessive amniotic fluid. Coexisting spina bifida is also common with anencephaly. Increased fetal activity because of irritating effects of amniotic fluid on exposed meninges and neural tube. Fetuses with anencephaly are correctly identified at 12 to 13 weeks of gestation. Anencephaly occurs in absence of the cranial vault. Ultrasound findings can be normal until onset of association has definitely failed. A first trimester scan at 12 to 13 weeks allows reliable diagnosis and active management of anencephaly. So here are the all eyes, and it looks like that: prominent eyeballs, protruded eyes. These are the eyeballs, and this was the gender, nasal bone, and eyeballs of anencephalic fetus. This is anencephaly with deformed spine. This is the spine which is deformed. A newborn with anencephaly and 3D appearance. No detectable vascularity, so there will be no circle of Willis. This is how anencephalic fetus will appear at 15 weeks of gestation. There will be characteristic of motoric activities of anencephalic fetuses, which are head movement are forceful without variability of direction. So they keep on moving head in one direction, but forcefully. Hand movements in several directions, hand to face, hand to mouth, and hand to eye. There will be general movement in first trimester with lack of positional changes, high amplitude and hypertonia, waxing and waning in intensity. Frequency of all movement patterns is decreased. All movement patterns are not there. Specific patterns which are forceful are seen. Second is acrania. Acrania is a rare congenital disorder, whereas anencephaly is most common. Occurs in fetuses in which the flat bones in the cranial vault are either completely or partially absent. The cerebral hemispheres develop completely but abnormally. Acrania is a fetal condition. Infants with acrania are stillborn in about 75% of cases. Newborns who survive die within several hours, days, or weeks. Anencephaly-Sonographic findings are the presence of brain tissue without the presence of calvarium, no cranium visualized, brain matter freely floating within the amniotic fluid, polyhydramnias. We need to keep these while diagnosing acrania, that these are specific findings of anencephaly. But if we get brain matter, a part of brain matter, you can see here it is. The eyes are prominent, but that are not that much protrudent, are not resembling frog eye or all eye appearance. There is brain matter, but it is not a bird. It is bigger than a bird. A bird is seen in a brain bud is seen in cases of anencephaly, whereas here we can have a complete formation of the brain hemispheres. Only the skull will be absent. This is 4D. The brain matter is absent. Only a bud is there. It is anencephaly, and you can see the brain matter. The brain matter is smaller here. This is the protrudent eye, so it is anencephaly. And in acrania, the brain matter is there, and only the skull is absent. So this is acrania. Here is acrania again, the brain matter in the cut section. On 3D, the acrania will appear like this. All of the brain matter is there. These are the normal sutures. So skull is there. If this skull is absent, it will be acrania. Acrania at 10 weeks on 2D and at 3D. The brain matter is there floating in the amniotic fluid. Acrania, no cranium. These are the bones. This is normal skull. So no skull, no suture seen. Difference between acrania and anencephaly. Anencephaly is a neural tube defect, whereas acrania is failure of mesenchymal cells to migrate and cover the neural tissues. So the bone is not formed. In anencephaly, both calvarium and cerebral hemispheres are absent, so brain tissue is less, whereas in acrania, there is abundance of functionally abnormal brain tissues. Then comes the anencephalocele, the third anomaly of the skull. Anencephalocele are neural tube defects with herniation of the brain and meninges through a congenital defect in the skull bones. Anencephaloceles commonly involve the occipital bone and are usually located in the midline. Anencephalocele defect characterized by sac-like protrusions of the brain and the membranes that cover it through opening of the skull. These defects are caused by failure of the neural tube to close completely during fetal development. So here is the anencephalocele. This is after operation. The same fetus after birth and operation. And this is operated. This was the defect, skull, a small defect at the back. And then the brain matter is herniated out. This is from another angle. Here is another one, and you can see the skull and large defect. The whole of the brain is going out. These are the meninges, and this is a pouch-like structure on the back of the skull. This is a clear view of the same fetus. Large defect. It is floating out through a sac-like structure. Anencephalocele, which is also called occipital anencephalocele. This is another case, the skull, the fetal head, and large defect. The meninges and brain matter are protruded, herniated in the posterior aspect of the skull, which are the occipital. This is another one, a defect, but brain matter, small part is herniated. Then are meninges and some fluid. This is another case. There is a large defect. These are the skull bones and the herniated brain. Then is ventriculomegaly. As the name indicates, it is a condition in which the ventricles appears larger than normal on a prenatal ultrasound. This can occur when the CSF becomes trapped in the spaces, causing them to grow larger. Ventricles develop early in pregnancy and can be seen on a prenatal ultrasound in the second trimester at about 15 weeks. The right and left lateral ventricles are structures within the brain that contain cerebrospinal fluid, a clear watery fluid that provides cushioning for the brain while also helping to circulate nutrients and remove waste. Types of ventriculomegaly. Normal dimensions, when we measure the width of the ventricle, it must be less than 10 millimeter or 1 centimeter. So anything above 9 mm will be crucial, will be suspicious. Mild borderline ventriculomegaly is 10 to 15 mm, moderate is 15 to 20, and severe ventriculomegaly is about or above 2 centimeters, which is 20 millimeters. This is how we differentiate according to the severity. Here you can see on one side is 25, the other is 20. So we can say it is bilateral severe ventriculomegaly. You can see the brain matter is pushed, excessive dilatation is there. The same fetus having spina bifida with meningocele, with covering. It is ventriculomegaly with meningocele at the sacral region. This is another one in which you can see the distance is 2. Again, severe. A case with large cisterna magna along with ventriculomegaly. We will discuss the pathologies of cisterna magna later in this lecture. This is ventriculomegaly again. Then is hydrocephalus. When there is an obstruction within or outside the ventricular system, the ventricles dilate as the flow of CSF is blocked. This in turn causes the pressure within the obstructed ventricles to increase, leading to ventricular expansion. So nowadays we have replaced the term of hydrocephalus with ventriculomegaly, and we have its types, which are mild, moderate, and severe. But still, for ventriculomegaly, the common term which is used is hydrocephalus, means large head with water inside. The abnormally enlarged ventricles exert pressure on the brain tissue, which may lead to irreversible brain damage. Hydrocephalus, it does not go away on its own and needs special treatment. Hydrocephalus is due to the accumulation of cerebrospinal fluid in the cavities deep within the brain. So hydrocephalus is typically detected through a prenatal ultrasound between 15 to 35 weeks of gestation. And we can perform MRI for that. The difference between ventriculomegaly and hydrocephalus. Ventriculomegaly, also known as hydrocephalus, is a condition in which the CSF-filled structures within the brain becomes larger than normal. As a result, the large ventricles can inhibit the proper development of the brain. So we will recommend the term of ventriculomegaly must be preferred as compared to the hydrocephalus. This is meningocele along with hydrocephalus. You can see even the falx cerebri is not visible. Whole of the skull is with fluid. We have to perform differential diagnosis for it. We will have a few more pathologies which we will discuss, and then we will talk about the differential diagnosis of such type of presentation. If you get just fluid, what are the other possibilities? This is hydrocephalus, bilateral ventriculomegaly, and here is again only fluid is visible. Then comes the microcephaly. This is the normal head and smaller head. A microcephaly is a condition where a fetus head is much smaller than expected. During pregnancy, a fetus head grows because the fetus brain grows. Microcephaly can occur because of a fetus brain has not developed properly during pregnancy or has stopped growing after birth, which results in a smaller head size. Some children with microcephaly are both with a normal intelligence and have normal development milestones, but their head will always be smaller than the normal children. We also call them constitutionally small heads. They are smaller in parameters, in biometric parameters, but they are normal functionally. Early diagnosis of microcephaly can sometimes be made by fetal ultrasound. Ultrasound have the best diagnosis possibility if they are in the second trimester, around 18 to 20 weeks of gestation. It demonstrates impairment of head growth. There is BPD and head circumference, which is above 3 standard deviations below normal abdominal circumference and femur length. So 1 standard deviation will be 0.5 in size and 1 week according to the weeks. So if the gestational age measured by BPD and head circumference is 3 weeks less than the gestational age assessed by abdominal circumference and femur length, we label it as small head, which is microcephaly. Causes of microcephaly: prenatal infections, exposure to the Zika virus, especially in the first trimester of pregnancy, can damage nerve cells in the brain. Zika virus can be transmitted from mother to fetus during pregnancy, resulting in microcephaly and other congenital abnormalities in the infant, collectively referred to as congenital Zika syndrome. This is the gestational age by femur length is 27 weeks. whereas by BPD is 23 weeks, 3 days. So 4 weeks difference. The head is 4 weeks smaller than the gestational age determined by femur length. We will also measure the head circumference. If it is also 23 weeks, 3 days, it will indicate that it is not a dolichocephaly, it is not a longer head in which the biparietal diameter decreases and occipitofrontal diameter increases. So head circumference will be important to measure in such cases. And here we will also take the abdominal circumference in order to rule out the large long bones. Sometimes there are larger long bones in some of the regions in some of the ethnic groups. Here you can see the abdominal circumference is 36 weeks, femur length says 37 weeks, BPD is 32 weeks. So more than 3 weeks difference. Again, head circumference is being measured, but it is not in these measurements. So this was a microcephaly. Another microcephalic in which the gestational age by BPD is 21 week 4 days. Fever length is 28 weeks. So about 7 weeks difference. Very small head. 26 weeks BPD, 33 weeks femur length. Again, there is difference, but keep in mind before giving the diagnosis of microcephaly, you have to rule out asymmetrical IUGR, brain sparing phenomena, and dolichocephaly. We have to see the abdominal circumference, femur length, head circumference, and BPD, all 4 parameters before we diagnose that there is a difference of more than 3 standard deviations or 3 weeks between abdominal circumference, femur length as compared to head circumference and BPD. So microcephaly refers to an overly large macrocephaly, sorry. The macrocephaly is a larger head. It's often a symptom of complications or conditions in the brain. There is a standard used to define macrocephaly. The circumstances of a fetus head is more than 2 standard deviations above average of their age. Again, the comparison of head circumference, BPD with measurements of abdominal circumference and femur length will be done. If the gestational age calculated by BPD and head circumference are more than 2 weeks as compared to the other parameters, we will label it as macrocephaly, larger head. Now we have to rule out either this larger head is due to ventriculomegaly or intracranial pathology, intracranial bleed, any of the pathologies like ventriculomegaly. So we have to rule it out. So macrocephaly will be a larger head. The causes may be caused by conditions. The most common causes are enlarged head are megalencephaly or an enlarged brain and hydrocephalus or excessive cerebrospinal fluid, which is the ventriculomegaly. When macrocephaly is a result of megalencephaly, it is often impossible to determine the cause. Here is a fetus having BPD 34 weeks and another fetus having 37 weeks in twin pregnancy. So in twin pregnancy, again, we have to rule out many other reasons like twin-to-twin transfusion syndrome. This was 37 weeks. What will be the distinguishing features? This slide is important. Hydrocephalus, the cerebral tissues are present. Fox is present. Thalami not fused. We can differentiate between thalami, midline cavity, which is the line not properly visible. Dangling choroid can be present. Mid-face abnormalities, no mid-face abnormalities. Holoprosencephaly, cerebral tissue is present. Fox not visible because they are fused. Fused thalami, midline cavity, yes. Dangling minimal, and middle face abnormalities are present. On face, you can have a proboscis, you can have a central fused eye lying in the center of the forehead. And the third condition is hydranencephaly. Cerebral fluid tissue is not seen. Why? Because in most of the cases, the both internal carotids are obscured or occluded. Fox is seen. Thalami looks normal. No midline cavity. Dangling choroid not usually seen. Mid-face abnormalities not seen. Hydranencephaly, it is lethal, sporadic malformation, absence or near absence of cerebral hemispheres with preservation of midbrain and cerebellum, midline posterior structures, preserved fox, occipital cortex, and midbrain. Presents late second or third trimester, normal 20th week scan. Here it is, the normal brain. And here you can see the cerebral hemisphere virtually absent, replaced by membrane sacs of cerebrospinal fluid. Vascular injury, bilateral in utero, internal carotid arteries infarction. So internal carotid arteries are not formed. This is the condition of hydranencephaly, in which the cerebral hemispheres are not formed, the vasculature is not formed. So we will just see the hindbrain. Here the hemispheres are there. Then is anencephaly, sphere abnormality of the spine and vertebrae with the brain and much of the spinal cord occupying a single cavity. Ultrasound shows acute angulation between fetal skull and spine. This is anencephaly, in which the fetus will be a bit having flexed neck, and we will have vertebral and spinal abnormalities. Then is holoprosencephaly. Holoprosencephaly, as we saw in the differential diagnosis slide, will have mid-face abnormalities. Fused thalami, which can be partially or completely fused. There is single eye and a structure which is at the center, which is called proboscis. This is the prosencephaly, which is the forebrain, midbrain, and hindbrain. So holoprosencephaly is a disorder in which the prosencephalon, this one, the forebrain, fails to develop within two hemispheres. Normally, the forebrain is formed and the face begins to develop in 5th to 6th weeks of human pregnancy. Hox genes, which guide placement of embryonic structures, fail to activate along the midline of the head, allowing structures that are normally paired on the left and right of the merge. So the Hox-linked gene is defective in holoprosencephaly, which, if present, will allow to differentiate between right and left eye, right and left ear, and the structures which are two in number in the face. But if it is absent, we will get a single proboscis instead of a nose with two nostrils. And instead of two eyes, there will be a single eye. The eyeballs are not separated, they look fused. Holoprosencephaly is a rare spectrum of cerebral and facial malformation resulting from incomplete division of the embryonic forebrain into distinct lateral cerebral hemispheres. Holoprosencephaly spectrum in the fetus is often associated with other anomalies, particularly of the face and extremities. Holoprosencephaly occurs when the brain fails to divide properly into the right and left hemispheres. So holo means whole, probos means forward, encephalos is brain. So the holoprosencephaly, failure of cleavage of midline neural and facial structures with resultant absence of forks and corpus callosum. Intracranial midline cystic mass representing single lateral ventricle. So we will get proboscis, cyclopia, which is a single eye, single nostril, and midline facial cleft lip. This is the shape, how it appears. This is proboscis. Here it is, the single eye, nose is absent. These are different shapes. We can have cleft lip and cleft palate. This is sonographic appearance in which there is fused thalamus. We can have a crescenteric shape appearance of the cerebral structures. This is a ventricle, single ventricle crescenteric shape. It can appear like this. The cleft or cyclopia is of different types. Here you can see, here the eyes are not fused, they are separated, but it is affecting this area. Nose is not properly formed, there is cleft lip. Whereas here we have proboscis, the eyeballs, there are two eyeballs, they are fused together, nose is absent. Proboscis, nose is absent, here it is absent, and eyeball is a single fused eyeball. Is a central crescenteric shape ventricle. Cyclopia is a rare form of holoprosencephaly and is a congenital disorder but defect characterized by the failure of the embryonic prosencephalon to properly divide the orbits of the eye into two cavities. So it remains single like this. This is proboscis. Then comes Dandy-Walker malformation, which is the partial or complete absence of cerebral vermix, enlarged cisterna magna, a large posterior fossa cyst, continuous with the fourth ventricle, elevation of the tentorium and splaying of the cerebral hemispheres. Associated hydrocephalus can also be seen. Here you can see the occipital region, cerebellum, vermix of the cerebellum is not formed. That's why we call it agenesis of the vermix of cerebellum. The two lobes of cerebellum look separate, which increase the distance of which is the cisterna magna, which in any condition must be less than 0.5 millimeters. 0.5 centimeters, which is 5 millimeters. So in this way, it will increase because we will measure from here to here. This is large cisterna magna again, agenesis of the cerebellar vermix done in 2004. Large posterior fossa cyst, which is Dandy Walker. Then we can have choroid plexus cysts. These are collection of the cerebrospinal fluid due to blockage of the glands in the choroid plexus. They are seen in 1 to 3% of the time of the abnormal scan. These are choroid plexus cysts. They can permanently resolve from 15 to 24 weeks. So if you find any choroid plexus cyst, you can wait till 24 weeks so that if there is possibility, they will resolve. In chromosomal defects or Down syndrome screening, it is a minor scoring in the scoring criteria. It is one of the minor characteristics. So if it is lying alone, it has got 1 score out of 2. If along with this we get other findings and the total score is 2 or above, we can label it as a candidate for diagnosis of karyotyping to diagnose the Down syndrome. The cyst size ranges from 0.3 to 2 centimeters. Here is the choroid plexus cyst. Then comes the Arnold-Cherry malformation, herniation of the only cerebellar tonsil not associated with myelomeningocele seal. Type 2 is herniation of the cerebellar tonsil and brainstem, medullary kink, tentorial dysplasia associated with myelomeningocele. The first is not associated. Type 3, associated with the encephalocele, which is also called sphalocele, or craniocervical meningocele, in which cerebellum and brainstem are herniated. These are that conditions. So it is Arnold-Cherry, in which we can also get the dangling choroid. Strawberry-shaped skull. The finding should raise the suspicion of trisomy 18, which is Edwards syndrome, tapering of the frontal bones, also called Lemon sign. In Meckel-Grubber syndrome, we get polydactyly, encephalocele, herniation of the brain matter through a defect in the skull, in the posterior of the skull, and then is the polycystic kidneys, bilateral polycystic kidneys. Vein of Galen aneurysm, which is a rare arteriovenous malformation, a cystic space that may be regular in shape or and is located midline and posterior superior to the third ventricle. We can easily diagnose the AV malformation, vein of Galen aneurysms with the help of color Doppler. Then are the main facial anomalies. This is yawning, 3D. And here you can see cleft lip. Is 3D of the cleft lip. We can have multiplanar surface rendering, reverse view and rotation cine to diagnose the cleft lip or any facial defects. This is the fetal ear. In trisomy 18, we will have dysmorphic ear, irregular. This is normal ear, and this is dysmorphic ear. In Down syndrome, we will look at the level. This is according to the eye, the lower part of the eye. If the proximal part of ear is below the mid of the eye, that rises the Down syndrome suspicion. Abnormal face profiles include the micrognathia, absent nasal bridge, absent nose, frontal bossing meshes. This is achondroplasia, in which you will get the frontal bossing and depression of the nasal bridge. Cleft lip. This is the normal palate, normal lips, unilateral, one-sided cleft lip and palate, and bilateral, both sides. It will appear like this. This is bilateral cleft lip and palate. This is unilateral cleft lip and palate. This is normal. Here you have. Now here you can see that it is unilateral, this sided. Here is again a unilateral cleft lip, left sided. So cleft lip and cleft palate can be seen in different angles in the cut sections. The types of cleft lip and palate can be alobar, most severe form, semi-lobar, intermediate, and lobar, which is the mildest. Then is micrognathia with cleft lip at 19 weeks, in which there is almost no chin, very small chin. Micrognathia, almost no chin, 17 weeks, 20 weeks, 29 weeks. It is bilateral cleft lip at 35 weeks, both sides. This is right and left. And on 3D also. There are different defects which can occur at the rostral end, at the spine level. This is the meningeomyelocele. We can have Anencephalocele. Look at this, hernial protrusion of brain distended by fluid through an opening of the skull in the frontal area. This was after operation. This is again frontal meningocele, and after it was operated. This is how it appears. If it is on the back, this is Anencephalocele. If it is in the front, we will call it Anencephalocystocele, which is frontal. Anencephaly, in which the neck is not properly formed, it is over extended, and we can have a deformed body and spine. Here it is. For fetal neck, we can have interiorly thyroid, such as fetal goiter, teratoma, hemangiomas, whereas in the posterolateral we can have hygroma, most frequently encountered neck mass seen prenatally. In the neck, another important thing is the nuchal translucency. We measure at this area. The best time is 11 to 14 weeks. And Sensitivity for all aneuploidies is 73%. Trisomy 31 is important. It is important for it, which is Down syndrome. This is where we measure the nuchal translucency, this area, the black area, the anechoic area. We have to differentiate it from the cystic hygroma, which is a cystic mass around the neck. It is multicystic, medial and bilateral position, whereas this is nuchal translucency is non-septated and medial position. It is transient, goes away at 14 weeks, whereas this remains there. This is nuchal translucent area, nuchal translucency here. If we include the skin, we call it nuchal fold. This was about nuchal translucency. So, location of the fetal neck meshes, the cervical teratoma, anterior lateral, it can be bilateral. Goiter is anteriorly, it can be bilateral. Cervical meningocele, occipital scapholocele, posterior. Cystic hygroma is posterolateral, it can be bilateral. We can have hemangiomas which are variable. Cystic hygroma is less common. Common is cystic hygroma, and other less common neck meshes are cervical meningomyelocele, occipital cephalocele, goiter, teratoma, hemangioma. Rare are neuroblastoma, hemangio, endothelioma, lipoma, fibroma, brachial cleft, or thyroglossal duct cysts and metastasis. The cystic hygroma is a cystic mass around the neck. This is cut section of the neck showing septated cystic mass around it. And here you can see again the cystic hygroma. This is increased area. We will get the cut section and septated areas, which means it is not increased nuchal translucency. It is a cystic hygroma. This appears like this. It was a trisomy 13. This is how it appears, cystic hygroma. Then comes the fetal goiter, enlarged thyroid gland, results in hyperthyroidism. This is the thyroid. So we have to look the front of the neck of the fetus also. This is increased in size in 3D images. Then we can have hemangiomas, which is vascular endothelial proliferation anywhere in the body. Most are solid and uniformly echogenic. Pulse Doppler will confirm. It may cause a congenital heart disease. In spine, we have to see the spine longitudinally and then transversely at different levels, at least at 3 levels. At the cervical region, the thoracic, the dorsals and sacrals. We can have different types of, this is a normal spine, the spina bifida occulta with meningocele and with meningomyelocele, in which the spine are also there, spinal tissues are there. This is meningocele and meningomyelocele. Here you can see the spina bifida in longitudinal section and cut section. This is also defect with clubfoot. The meningocele again. Bilateral ventriculomegaly in the same patients with meningocele. Here are the ribs and spine. Irregular, you can see the curved spinal cord. This is the normal one, so it is scoliosis. This is spina bifida. Another case of spina bifida. Angiomyloceles, a deformity. Here you can see the sphere scoliosis. This is hemivertebrae. Retroflexed abnormality, retroflexed fetus. Look at the head. We can have fused vertebrae again. These are the fused vertebrae appearing like one bone. In thorax, we can have some abnormalities like, let us discuss the main thoracic abnormalities. Like we can have fluid, which is the pleural effusion. This is pleural effusion. Here we have the pleural effusion with pericardial effusion. This is sagittal view and cut section. We can have congenital diaphragmatic hernia, which can be diagnosed at 6 to 14 weeks. Progressive intermittent pulmonary hypoplasia is seen. We can have pulmonary hypertension. There is congenital defect in the diaphragm, usually on the left side. And from there, the stomach is herniated in the thoracic canal. Here is heart. Along with that, stomach is present in the thorax. We can also have pulmonary hyperplasia and some of the messes. I will not go in detail of that. Then another important thing is cystic adenomatide malformation, failure of induction of mesenchyma by bronchiolar epithelium. It has different degrees, type 1, type 2, type 3. Like type 1 is the macrocystic, type 2 is mixed, and type 3 is microcystic. This will appear more hyperechoic as compared to the macrocystic. They will be appearing larger, multiple cysts which are visible in the macro. This is macro, in which you can get some multiple cysts in the thorax. This is mixed type, in which you get some and remaining is hyper. And in microcystic, whole of the lungs will be very hyperechoic. The cyst will not be visible as in polycystic kidney disease. We can also have bronchogenic cysts, which are large cysts. The last thing is fetal abdominal anomalies. The main is omphalocele, which is the herniation of the abdominal contents into the base of the umbilical cord. Herniated mass can contain bowel only or liver and spleen, stomach and bladder, uterus and ovaries. Herniated contents typically have covering amniotic membrane and polyhydramnios is seen. This is how it is herniated along the cord, where it is the early diagnosis of omphalocele. This is a 12 weeks aborted fetus, and here you can see also at the 3D, 4D omphalocele. We usually diagnose it after 12 weeks because till 12 weeks we can have late regression of the physiological herniation of the gut. This was a prawn belly syndrome, in which you can get a large urinary bladder which is visible, and along with that there will be omphalocele, fetal ascites, in which there is fluid, lot of fluid is there. This is ascites. Gastroschisis is another condition in which the abdominal contents are herniated from the interior abdominal wall, usually on the right side of the cord. This is cord, and on the right side of the cord, there is a defect, and here we have multiple herniated structures. Gastroschisis is usually defect of the interior abdominal wall is not more serious as compared to the gastroschisis because the omphalocele is usually associated with chromosomal abnormalities, so it is more dangerous. Although it is covered, with the membrane. But here, there is a danger of necrosis of the structures by the amniotic fluid. Otherwise, it is just defect which can be repaired after birth. These are that conditions. So with this, we finish the